Welcome to the doctor's room. Please subscribe so we can keep sharing clear surgical guides like this. Today, we will walk through the open appendectomy step by step. This procedure is indicated for acute appendicitis or appendiceal mass, not suitable for conservative management. Always take informed consent, discussing risks such as wound infection, intra-abdominal abscess, bleeding, bowel injury, ileus, and adhesion-related complications. Administer prophylactic antibiotics according to protocol. The procedure is usually performed under general anesthesia. Position the patient supine with arms by the side. Prep the abdomen from nipples to mid-thigh. Drape to expose the right lower quadrant. Make a skin incision at McBurney's point, 1/3 of the distance from the anterior superior iliac spine to the umbilicus. Length is typically 6 to 8 centimeters. Incise through subcutaneous tissue and the external oblique aponeurosis in line with its fibers. Split the internal oblique and transversus abdominis along their fibers, taking care not to injure nerves. Enter the peritoneum under direct vision. Locate the cecum and follow the taenia coli to identify the appendix. Gently deliver the appendix into the wound. Place a moist pack around the operative field to minimize contamination. If a mesoappendix is present, divide it with serial clamps and ties or a vessel sealing device. Control the appendicular artery securely. Mobilize the appendix fully to its base. At the base, place a crushing clamp about 5 millimeters from the cecum. Remove the clamp and tie a transfixion suture of absorbable material at the crush site. Place a second ligature if needed. Divide the appendix between the ligature and the clamp. Remove the appendix from the field. The stump can be managed in 2 ways. Simple ligation with the stump left exposed is common. Alternatively, it may be inverted into the cecum with a purse string or Z suture placed in the cecal wall. Choose the method according to surgeon preference and intraoperative findings. Inspect the stump for bleeding or leakage. Irrigate the operative field with warm saline. Suction thoroughly. Remove the protective packs and check for hemostasis. Close the muscle layers by approximating the internal oblique and transversus with absorbable sutures if they were split widely. Reapproximate the external oblique with continuous absorbable sutures. Close subcutaneous tissue as needed. Close the skin with sutures, staples, or subcuticular technique, depending on contamination level and surgeon preference. In contaminated cases, delayed skin closure or drain placement may be considered. Postoperatively, provide multimodal analgesia and early ambulation. Resume diet once bowel sounds return. Monitor for fever, wound infection, ileus, intra-abdominal abscess, or leakage. Most uncomplicated cases can be discharged within 2 to 3 days. Thank you for joining the doctor's room. Subscribe for more surgical walkthroughs and leave questions or cases in the comments below.